In the coming months, we all hope to have good news about a vaccine for COVID-19. But if and when we have an effective vaccine, we must also use it effectively. When supply is limited, the first priority must be to vaccinate some people in all countries rather than all people in some countries. Vaccine nationalism will prolong the pandemic, not shorten it.
Hi everyone, I'm your co-host Theresa.
And I'm your co-host Nanna. And on today's episode of Global Get Down, we'll be discussing the COVID-19 vaccine in the context of international relations and global health. Almost a year ago, in the beginning of March 2020, we put out an episode on COVID-19 where we discussed some of the early implications of the outbreak.
Associating the virus with a particular group. We see people stocking up on food and panicking. And then now we have a stock market crash, right? Again, today, the stock market went down.
But a lot has happened since then. So it only seems fitting to revisit this situation today.
Absolutely. In just a year, and despite the fact that vaccine development can take an average of 10 to 15 years, we already have several available for use. But a lot of questions remain as to how exactly we can go about vaccinating an entire planet. In a globalized age, as the WHO has put it, no one is safe until everyone is safe. So how can we overcome massive inequalities in access to vaccines and healthcare? How might international politics or rivalries get in the way? And how can we transform these challenges into valuable lessons for future global health crises?
To help us answer these questions, we've brought on Dr. Prince Adu from the School of Population and Public Health and Godwin Dzah from the Peter Allard School of Law. Dr. Adu and Godwin, welcome to the show. Would you like to introduce yourselves?
Yes, thank you very much for having me. I teach 2 courses at the School of Population and Public Health. I teach an undergraduate course called Working in International Health, and then I teach a graduate level course called Global Health and Human Security. I'm also a postdoctoral research scholar at the BC Center for Disease Control, where currently I'm involved with some COVID-related research.
Hi, my name is Godwin, and I'm a doctoral candidate at the Peter Allard School of Law, and I'm a TA in the School of Population and Public Health, working with Dr. Adu, and my research is focusing generally on international law, more precisely on sustainable development, and I've also worked in the past as a consultant for the United Nations offices on the Children's Fund, that's UNICEF, and also with the UNDP, the Development Program, and also UNFPA, the Family and Population Office as well.
Thank you. So let's get right into the first question. How have global inequalities been exposed in the process to develop, procure, and administer the COVID-19 vaccines?
I think that there are 2 perspectives that this question brings up. So just to make it quite short, there's an economic challenge here, and then there's also a health challenge. And in the sense of economic challenge, it has been announced that if we do not grant equitable access to vaccines across the world, perhaps this year alone, the global economy would contract by 9.2 trillion. And that in itself does not leave out poor countries, because as you know, the globalized nature of the global economy itself requires that transactions are cross-border, transactions are more transnational. So that's going to be impacted by our unequal and inequitable access in relation to the vaccine. Secondly, even if we take it that the vaccines have been produced and are now being distributed, the stark reality is that as of the end of January this year, if you recall, the vaccinations began sometime in the first week of December last year, and as of 31st January, there have been in the region of 70 million vaccines that have been administered, with only 20,000, for example, being sent to Africa. Now, if you look at the quantity of vaccines that have moved in the global north compared to, say, the whole of Africa, which has a little over 1 billion people, then obviously 20,000 in 6 weeks of start falls greatly below the expected thresholds that we would envisage in an equitable, distribution system that we are all looking forward to. So these are the two concerns that I want to put up. But then they are directly linked to what is emerging as the concept of vaccine nationalism, the idea that countries are pursuing more self-interested and self-centered goals in direct connection with their national interests, which is not bad in itself, but it exposes these shortcomings because we're dealing with a pandemic, and since it's a global concern, handling it at the national level or state-specific level defeats the ultimate purpose of fighting the pandemic.
Absolutely. I mean, I think just as I've been reading articles on this and seeing, as you were mentioning, the vast differences in which countries have been vaccinating their populations and seeing even the supplies that countries have ordered. I mean, I read that Canada, I think, has ordered enough doses to immunize like 500% of the population. That's in stark contrast to a lot of other countries in the world. And it's kind of funny. I read a quote and it said, rich countries buying up vaccines before they're even available is not unlike people hoarding toilet paper, which is just sort of bringing it
Right.
back to, this time last year, but on a whole new level and obviously a lot more concern. I mean, is there any sort of international plan or framework to make sure that vaccines are distributed equally? I mean, does the WHO have a framework for countries to follow or that it recommends?
So when so there is I'll tell you something. There's always a plan, but as to whether the plan is being adequately implemented, that's a separate question. But in the beginning of September, specifically September 9th, the WHO unveiled its plan. It was called the Fair Allocation Mechanism for COVID vaccine, through the COVAX facility.
The facility is critical, the critical mechanism for joint procurement and pooling risk across multiple vaccines so that whatever vaccine is proven to be safe and effective, all countries within the facility will be able to access them.
The plan was that once the vaccines were shown, because at the time, there was a race for effective vaccine. And so the plan or the expectation was that once the vaccines were shown to be safe and effective and authorized for use, then the plan was that countries will receive doses in proportion to their population size, right? And so they had the plans were set up in two steps. So the initial plan was initial proportional allocation of doses to countries' population until all countries reached at least 20% of their population. And then the follow-up plan or phase was to expand coverage to the rest of the population. So this was the ideal plan. And way back in September, before we had, just right after the Sputnik 5, because that was somewhere around mid-August when the Russians developed their vaccine, which unfortunately did not receive much attention or, much positive or the expected attention. We didn't get it here in the West. But so to answer that question, yes, there is a plan, but what do we see now? As Godwin has already talked about, it's been very disproportional. Countries have really more than what they need. Poor countries don't even have a fraction. So there is a plan, but the plan has not been followed the way it should have.
Yeah, so there have been some concerns that poor countries have been turned into quote unquote guinea pigs for vaccine trials.
The vaccine is being tested by Britain's Oxford University, but the trial, consisting of 2,000 volunteers in South Africa, has also prompted a fresh wave of anti-vaccine sentiment, reflecting fears of Africans being used as guinea pigs.
Could you explain what this means and how it relates to global inequalities?
Yeah, just briefly, it's a bit contentious. So it is true, but in short, the statement is trying to shed light on the fact that, poor countries as their context or these populations are used for vaccine trials, right? And, but the other question too is it's a bit tricky because on one hand, you would have to test some of these new products. And I'm using product to capture with vaccines or equipment. You would need to test them in different contexts, right? To improve its, you call it external validity or its ability to be used in different contexts. But there's that issue of, well, are you just testing it because of the poor regulatory environment in these areas? So are you taking advantage of the populations or not?
Godwin, did you want to hop in?
It's an interesting question. It's one that goes to the heart of some of the things that I do in my studies. So last year, sometime in April, there were two French researchers who suggested that vaccine trials should take place in Africa, and this was widely published. So it's not make believe. It's this record to that. But their suggestions were roundly rejected by a lot of researchers and African leaders. And but the real challenge with a statement like that by researchers sort of takes us back to what has been discussed in post-colonial studies, for example, as medical colonialism, where new forms of um, medications, new forms of medical procedures are sort of tried out on some people in other parts of the world other than in the global north. And when the efficacy of those medications or those processes are sort of measured, then the success, in quote, is repatriated to the north, and then it is used at a relatively lower price in the north. And then if those medicines or those practices or those medical interventions will be available to the south, it will come at a high cost. So you sort of like externalize the negative conditions that go with the testing, but then you take the positive back to the north. So there is some concern with this kind of statement that the south might be used as guinea pigs. Whether it is true or not at this moment, it is not the issue, because as it is playing out, it is the North at the moment that is receiving the vaccines.
And at the same time, as I understand, countries often agree to hosting these trials because they get access to the vaccines in return if they're successful.
Yes, it is true. But then it will be rather a very optimistic, extremely optimistic point just to make it so. Because what happens is that sometimes the quantity of the vaccines you are promised under the agreement may fall far below the what can help you to get herd immunity. Dr. Adu spoke earlier on about that. So the agreements are not entirely made as agreements between two equal parties. The agreements would tend historically and structurally to favor the where the global capital is situated, usually from the north. So these kinds of nuances must be accounted for in those kinds of situations.
So I mean, we've already kind of, even just in that the first couple questions, talked about how politics can play so much into vaccines and getting vaccines out, getting access to vaccines. So I want to talk now about the politicization of vaccines. We saw some examples. Iran banned vaccines from the US and UK.
Imports of US and British vaccines into the country are forbidden. I have told this to officials, and I'm saying it publicly now. If the Americans were able to produce a vaccine, they would not have such a coronavirus fiasco in their own country.
The USA was sanctioning vaccine developers in Russia.
The United States has added 5 Russian research institutes to its sanctions list. They include the Russian Defense Ministry Research Institute, which has been working on a COVID-19 vaccine. The US claims that these institutes have been involved in the research of chemical and biological weapons.
So how could the politicization of vaccines and geopolitics represent a challenge in vaccinating people around the world?
Well, it is it's a real challenge. I mean, it's quite clear. We are just mimicking the world geopolitical landscape, you know. So when you look at Sputnik 5s, the places where it's been approved and being used, well, recently, just yesterday, I had Mexico approved it. But so Hungary is the first, and I think right now is the only EU country. But the rest of the countries are all countries that we know are on the Soviet bloc. You know, so we have Bolivia, Belarus, Serbia, Palestine, Venezuela, and as you said, Iran. And Sputnik 5 was developed and way back somewhere in August, right? And it was always presented with doubts in the media.
And Dr. Gottlieb, what do you think of this news?
Well, I wouldn't take it, certainly not outside the
it was fed to us as, you know, not the way it was presented is quite different from the other vaccines that were developed from the West. And so it's not strange, but it's just an unfortunate situation that an issue like a pandemic is still being politicized.
Yes. So as Dr. Edu pointed out, we need to probably trace the genealogy of this COVID-19 vaccine, at least when we had the first vaccine till date. You know, short genealogy to sort of understand how the Cold War bipolarity is still alive, although in a different context. So Sputnik 5 is from Russia, the first on record. And and the Russians themselves created a very interesting scenario with the naming of the vaccine Sputnik, because we know that Sputnik is actually the race between the US and then the USSR over who was to send the first artificial satellite into orbit.
Our satellite Sputnik lifted at 22 hours, 28 minutes.
And the Russians beat them to it.
So, Dr. Newell, what about the vital question that everybody is thinking about? Why and how did the Russians beat us to the draw?
So it was interesting to see how the Russians chose to name this Sputnik 5, you know, in itself imprinting the geopolitical, you know, statement in a medical intervention. And then right after that, we had the Chinese Sinopharm come up with their own vaccine. Surprisingly, these two were never discussed as a matter of global concern in WHO records. It always seemed that they steered away from them, questioned their efficacy, questioned even the issue of whether they had completed the necessary trials that they had to go through. So when we put that in that context and you look at the news reports here, if you check most of the news reports from Washington Post all the way to CBC
Russia
News,
said today it's already
you'll
won,
see words like untested,
even though it hasn't completed phase 3.
Unproven,
COVID-19 that hasn't been clinically approved,
yet to be approved,
injected straight into the arm of Evelyn Wu last week.
And so these kinds of words signify to us that there was a rejection of a sort of those vaccines.
Already. A vaccine so quickly and from a country notorious for propaganda and deception.
And then came in Pfizer, Moderna, the Oxford AstraZeneca vaccines, and then boom, it seems that we had accepted that, and that became the basis for the WHO's own COVAX plan, you know, to kick in when they started buying up vaccines. What is of greater interest is that if we want to examine what this means in terms of vaccine efficacy, we know that Moderna is around 94, Pfizer 95. Just last night, the Lancet, which is one of the most leading medical peer-reviewed publications, reported that the Russian Sputnik 5 was safe and effective and rated at 92%, you know, much higher than some other ones that are coming up, the Astra vaccine, and I think the Johnson & Johnson one of them was around 89% at the moment. So clearly, if you look at the vaccine that is at 92% efficacy rate, why is the discussion not focusing on how that also plays into the global mix of vaccine access? So these are some of the subtexts that, you know, go behind the larger context of what we're seeing.
And just to add to that is the issue of even cost. When you check their Sputnik 5's websites, they are reporting about $10 per dose. Just $10. Now, the other vaccines, it's some of the figures are confidential. We don't have access to, but most likely way higher than that. So the efficacy is quite comparable, almost the same, or even higher. And when it comes to costs, talking about cost effectiveness, way cheaper compared to the others. But do we get to hear about it as much? No.
Absolutely. I mean, I think it's been so interesting
Mhm.
to see that because obviously, as you mentioned in the news here, there is a lot of skepticism when it comes to Chinese and Russian vaccines.
Mhm.
But then when you look at the vaccines that a lot of lower and middle income countries, especially, are opting for, they're opting for the Chinese and Russian vaccines. So there is this real question of, well, how much of it is science and legitimate concern, and how much of it is just politics and politicization of science kind of coming into it.
Right. These are political, and politics does not always follow facts per se or evidence. And so, I mean, Godwin will tell you the fact that this is the efficacy, it does not mean that the West will buy it, or it does not mean that then suddenly the US government is just going to order vaccines from Russia. No, there are other variables that would have to come to play.
Sure. I mean, particular attention has been paid to China and Russia, as we've just spoken about, and their willingness to supply vaccine to African countries, to Latin America, and Southeast Asian countries. And this move has been viewed with a fair amount of skepticism by Western media, who have tended to view vaccine diplomacy as another way of securing Chinese influence or Chinese imperialism, quote unquote. Is such skepticism warranted, or is this narrative potentially dangerous and, if unchallenged, a source of greater conflict that would impede real efforts for effective global health coordination?
I think that for everything that happens in the world, we need to have the hard context and the soft context. So vaccine supply or vaccine distribution already has within it the hardcore aspect, that is physical production and distribution, and then the soft issues of diplomacy, that is how do we use that to build new forms of global partnerships. So just a little bit of context. The Chinese did a very interesting thing here that gives legitimacy to the Sinopharm vaccine, because when they were doing the final stages of trial, the ruler of Dubai, Sheikh Mohammed Al Maktoum, he publicly took the shot on TV, and that was in itself a testament to that kind of relationship between the Gulf and China, and it raised a couple of concerns in the West that what was going on here. Now, when we look at the COVAX plan that Prince spoke about earlier, the challenge is that with advanced purchase agreements, which act as sleeping contracts, so when there are no pandemics or epidemics, these agreements are sort of dormant. But when there's a pandemic or an epidemic, they kick in. Now we are at a point where you have the uh, the the producers of the vaccines supplying countries in the north ahead of everybody else. So access to the COVAX vaccine would only be 100 million at most for the first quarter of this year, and way down the end of the year before we have maybe a half of about a billion or a billion plus. So developing countries, especially countries in the global north, are looking at alternative arrangements to this kind of challenge. So they have all kinds of arrangements that Prince mentioned with either Sinopharm or CanSino, which are leading producers of these vaccines in China, and also with the Russians Sputnik 5. You would notice that the US government has already placed some restrictions on some of the labs that are producing these vaccines in Russia, for example. So there's all kinds of contestations going on here. And because the pandemic is a serious crisis, spiraling out of control, it's interesting to see how states are taking advantage of the situation to sort of realign their relationships. So it is a necessary situation for states, especially in the global south, to redefine what their overall interests are and sort of leverage on whatever is happening between the superpowers and see how best they can create an enabling framework for them locally to be able to adapt to what is going on internationally.
Well, then moving on, we wanted to ask a little bit about equitable vaccine access and the role that international law could maybe play in that. What role can or does international law play in helping to guarantee equitable vaccine access for various populations, particularly concerning either countries that are being sanctioned and therefore face difficulties
Washington
accessing funds?
maintains food and medicine are exempt from its sanctions. But in practice, most international banks refrained from dealing with any Iranian transactions for fear of American
Or
penalties.
also for vulnerable populations living in conflict zones or under non-state
The Israeli
actors.
Minister of Health told Sky News it is not up to Israel to provide the vaccine to the Palestinian territories.
I mean, how does vaccine access work for them who kind of fall outside of the norm?
Godwin, I don't know if we can really be talking about law in this case, right? I mean, the WHO, it's the main body that's supposed to, be at the forefront of coordinating responses and with vaccine distribution, who is supposed to be allocated what. But they don't have the tools, the legislative instruments, or any legal. These are not legally binding things we're talking about here. Godwin has more expertise in this.
The first part of the question, I think, suggested what kind of framework we have, like global health framework. Well, perhaps just to go back a little bit, the COVAX plan is that plan. It's more or less the only equitable vaccine access program. The more difficult issue is for countries in conflict situations and for countries that have non-state actors or countries that are under dual governments like what we have in Libya, countries where there's turmoil over who really governs the country like Venezuela. These are quite distinct in the way they function. So the kinds of crises that we have in Venezuela is not the same as what we see, say, in Libya, for example. In Venezuela, Venezuela has actually written to the Pan American Health Organization requesting for COVAX support. So that request has already been made. It's the same with North Korea. North Korea has written for that support, and North Korea is not new to the kind of arrangement that we have. One of the partner institutions in this COVAX plan is the Gavi Alliance. The Gavi Alliance has supported North Korea with vaccinations for childhood diseases like polio, diphtheria, things like that. So these are not entirely new arrangements at all. The only question that this brings up is the security concerns. In 2015, 2016, some polio vaccinations going on in Taliban-controlled Afghanistan and Taliban-controlled Pakistan resulted in the death of some WHO officials because some Islamic fundamentalists felt that this was a violation of Islamic norms. So that put that program in jeopardy. Now, these are some of the real life situations that the WHO officials will have to confront when they go out there.
Right. Yeah, because I think there has just been this question of, well, first of all, even if there is international law governing this, I think it is really a matter of whether countries decide to follow it or not. I know that we were reading an article about Palestine and Israel concerning Gaza on the West Bank, where the UN was saying to Israel, it's your responsibility to make sure that Palestinians get access to vaccines. But then Israel was sort of saying, well, no, it's actually the Palestinians, it's their own responsibility under the Oslo Accords. So there's all these kinds of different laws floating around, and it just seems like there is no, as you're saying, there's no one answer or right fit.
Definitely. And the pandemic has also, posed significant ethical questions and challenges with regards to our healthcare systems, government priorities, and the role of private actors in the global health system. So I was wondering if you could talk a bit about in what ways has the pandemic exposed ethical questions with regards to our healthcare systems and government priorities? And where does the line exist in terms of generating profit and providing effective healthcare? And I raise this question because Oxford University was going to open source its vaccine, but the Bill and Melinda Gates Foundation was able to convince them otherwise and to sell exclusive rights to pharmaceutical companies. So there are clear ethical questions here. So I want to gauge with both of you a little bit about these kinds of ethical questions.
You know, the number one ethical concern that I see here is, and I'm calling it an ethical concern, it's nationalism. Maybe nobody really calls it an ethical issue, but I think it's about time we looked at it if we could call it an ethical issue here. And it actually defeats the purpose of, or it defeats the values embedded in global health or a global response to a pandemic. You know, so to me, I see that as the number one issue. Once we're able to move past that, you know, that sort of nationalistic approach to our handling of the pandemic in the individual countries, then that is a good step in how we are really going to address it. And how did it come about? I've had conversations about this with Godwin in the past, and he really saw this as a wave that has started way before even the pandemic, and he foresaw this being very, very detrimental to all of us. And unfortunately, the pandemic hit, and now we see this nationalism being played out here. It's the pandemic has definitely exposed us our emergency preparedness from a public health point of view. And so how where did we have enough? Was our capacities, our public health infrastructure, were they well strengthened or not? Or was our public health system just structured for profit making? Was there too much emphasis on pharmaceuticals as opposed to prevention? These are questions that we are definitely going to have to reflect on once this is over.
Now, the second thing, which is quite important, is as from a legal standpoint, probably like a political legal standpoint, is the ongoing contestation at the World Trade Center about the patent regime for a waiver of intellectual property rights to allow especially developing countries to produce generic vaccines based on the chemical compositions of brand names. Now, this is one of the hotly contested issues, and I'm glad Prince raised that issue where pharmaceuticals took over from research institutions to produce. But we need to put that in the context of how much public funds have been invested by governments into all the projects so far. There's not a single program that has produced vaccines without a huge inflow from public funds, either in the US, either in Europe, in Canada. So when we talk about big pharma or big pharmaceutical companies reaping their rewards, we need to situate this within the broader context of public welfare and look at the amount of money that has been put in there. Some economists are already calling it that we are paying twice the price for one item because the initial outlay that had been made is what has driven us this far, and that these things must be taken into account in how we condition the arrangements for pricing and distribution. So perhaps that is one of the key things. The public welfare element should be one of the key things that should drive this discussion. Once we lose sight of the public element, then all these discussions will fall through, and we'll get nowhere with our interventions.
Well, I was going to ask how vaccine prices are decided.
Well, yeah, that it will be hard to determine. So in a very competitive environment, as this what we are currently in, This sort of information are, confidential in most cases. Recently, and you only get it when they are leaked. And in fact, some information was recently leaked. And so even in Canada, it really came up. People wanted to know how much you're paying. So these are agreements that national governments make with these companies. And so as part of their contracts, the public may not be privy to this information. So to answer your question in short, how are they determined? Well, through negotiations, right, between the parties, national governments, the buyer, and the companies. And if we get them, usually for many reasons, right? Yeah, there are so many reasons, but mostly because of the current situation, the competitive nature of the markets. Everyone wants it. And so they wouldn't want to disclose.
The Commission understands fully the point that you're making about the interest of publicizing the prices of vaccines. What we are saying is that this was part of the process to conclude these contracts, and we are not in a position.
And again, because we lack a well-coordinated global health response to this, it will continue to play out like this, where country X does not know how rich country Y was able to negotiate and get those prices.
Right. And obviously that leaves all sorts of questions about, because of limited supply, whether bidding wars could ensue. And again, that poorer countries are going to get left behind. It all boils down to like the same inequalities, essentially.
Exactly. Yeah.
So we've kind of talked about some of the logistical issues, some of the political issues. We haven't talked a whole lot about public resistance to vaccines and how that could represent another problem. I mean, so I was downtown the other week, downtown Vancouver, and I saw a small protest going on against mandatory vaccination. And obviously this is something that has played out in a lot of countries, but I think it's kind of been skewed to countries in the global north, actually. I mean, one poll in France, supposedly 46% of the respondents said that they were unwilling to take the vaccine. So, I mean, why do you think there's been so much suspicion regarding taking the vaccine? And how can governments overcome this challenge? Like, is there a way to foster better trust?
It boils down to education. So I think two things. One, misinformation is key. There is, a lot of misinformation around, and when people are ill-informed, then it leads to some of these attitudes, right? But then also, there is also quite a legitimate issue here. Let me take you back to around 1930 all the way to 1972, the Tuskegee study. So this was in the US. They were conducting this study to study the natural history of syphilis by the US Public Health Service, right? So a major study. And the subjects or participants were a group of Black men. Now, when the treatments for penicillin became available in 1942, they weren't offered to these men. So, and they failed to provide information to them as well. And there were other unethical issues that came up in this study. It's well known, and the US public response has been affected by this unfortunate incidents where people are sort of misled and again marginalized people. We started off by talking about people being used as guinea pigs. And so these are still embedded in people's memory. There is deep mistrust with the authorities, plus misinformation, the age of misinformation. You have this issue of vaccine unacceptance or vaccine, but it's a very it's sensitive. It's a sensitive issue because some of the concerns are quite legitimate, but on the misinformation part, education is key. And I'll leave the rest for Godwin.
Right. So it's an interesting dimension to this whole discussion because most of the discussions that are happening at the very macro level, at state to state levels, or between states and drug producers, without much focus on what's going on or how people are preparing themselves to accept or to receive the vaccines. And we noted that even in, for example, in the US and parts of Canada and even parts of Europe, there were even anti-mask campaigns.
Wearing a mask is unhealthy.
They're fake, lying news to
I'm not
people.
endangering anybody by not wearing a mask.
So we cannot discount the question of disinformation and misinformation as the basis for these concerns. And also in Canada, women, for example, especially Indigenous women, were injected with all kinds of medication which led to their sterilization. As a result, some never had children again and didn't know why until recent royal commissions and other provincial commissions uncovered those kinds of situations. The same in the US as well. So if people have concerns about receiving the vaccines, we cannot easily discount that as unfounded. It has some history around it. The only way out of this is education, 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 and a lot of transparency with the side effects of these vaccines and making that information available is because to keep the public in the dark, then obviously we are giving room and space for the flourishing of conspiracy theory, the very thing that we don't want at this moment.
Right, absolutely. But we've just got one more question, just like a quick wrap-up question.
Yeah, this is a question submitted from our audience. How can we remove inequalities to access to vaccines? How do we advocate for free universal access to vaccine?
First, I think we need to strengthen our global health bodies. The WHO, it's unfortunately, it lacks capacity. It's heavily under-resourced. Canada's healthcare budget is around $265 billion. What do you think that the WHO's budget is? Well, it's about $5 billion, right? That's about less than 5%, it's about 2%. So it's a body we keep hearing of the WHO, yes, develop guidelines, coordinate response, but the capacity is very, very, very limited. And so we need to really strengthen these global health bodies, the WHO in particular. And then education is key to addressing some of these inequities.
For a start, we need the WHO platform, that's the COVAX plan, to succeed. Because if the plan does not succeed, there will be no success in individual countries. We need to understand that what is happening requires that everywhere in the world has comparable vaccine access. The variants we're seeing, say the Brazilian variant, the South African variant, if you did all the vaccination in Canada, in the US, if everybody took it 10 times over, and these strains came in, it's likely that we'll reinfect people and we'll begin all over again. The second thing is making vaccines affordable. The third thing that we should probably be looking at is to revisit our international legal regime for trade and how that configures pharmaceutical engagement, particularly whether we want to waive rights, at least for this particular matter, because really there's a lot of financial outlay, public funds already put into this research. And so we should not underestimate that public welfare that underpins this. I think that we should also look at alternative treatments. And there's research going on elsewhere suggesting that other countries are looking at other forms of treatment for this. And it's important that the WHO itself engages with those health practices going on elsewhere. It is interesting to note that, especially African countries who suggested that they had some treatment, the kinds of response from the WHO itself quickly rebuffing those treatments suggest for the global south that they're not welcome in this development. So if these kinds of research is going on in those places, we probably should approach it with an open mind, not with an outright rejection. I think that also gives some legitimacy to the validity of the work that the WHO itself does. especially in times like this.
So it almost seems as though there could be a degree of arrogance sort of and gatekeeping when it comes to, who gets to play a part in resolving this problem and who gets to kind of have to be the bystander, right?
Certainly.
Right. Who gets to be the hero at the end? Yep.
Dr. Adu and Godwin, thank you so much for joining us on today's episode of Global Get Down. And to our audience, thanks for listening, and we'll see you on the next episode.
Thank you.
Thank you.